The fluorescent lights above me flickered as I heard the most terrifying sound a cardiac nurse can hear, the flatline alarm piercing through the emergency room. "Stop the heartbeats!" the cardiologist screamed, his voice cracking with desperation as he stared at the monitor showing nothing but a straight line. Everyone in that room thought they knew what was happening, but I knew something they didn't. I knew about a cardiovascular condition so rare that most doctors go their entire careers without seeing it once. My name is Helen Winters, and I've been a cardiac nurse for 17 years, working between Seattle and Portland. What I'm about to tell you isn't just another day at the hospital. It's the day I had to choose between following protocol and trusting what my own broken heart had taught me. The patient lying on that table wasn't just another case number. His symptoms mirrored exactly what took my younger brother's life 8 years ago, and I wasn't going to let history repeat itself without a fight. I grew up in a small fishing town called Astoria, Oregon, where the Columbia River meets the Pacific Ocean. The constant fog and rain shaped who I am, patient, observant, and accustomed to seeing through things that aren't immediately clear. My father worked at the cannery, and my mother cleaned houses for the wealthy families up on the hill. We didn't have much, but we had each other, and that felt like enough until it wasn't. I was 21 when I decided to become a nurse, not out of some noble calling, but because I needed stable income, and my grades were good enough to get into nursing school. Portland Community College accepted me, and I worked double shifts at a diner to pay for it. The city was overwhelming at first. So many people, so much noise, such a stark contrast to the quiet mornings I knew in Astoria, where you could hear the sea lions barking from the docks. My clinical rotations introduced me to different specialties, but nothing captured my attention like cardiology. There was something about the heart, its rhythm, its resilience, its sudden fragility that felt deeply personal. After graduation, I landed a position at Providence Portland Medical Center, and that's where my real education began. The textbooks taught me about ejection fractions and arrhythmias, but the patients taught me about fear, hope, and the thin line between life and death. I learned to read not just monitors, but faces. I learned when a patient was declining before the machines caught it. I learned that sometimes the most important thing you can do is hold someone's hand while their world falls apart. For years, I thought I understood cardiac care. I thought I'd seen everything. Then my brother Daniel collapsed at a family barbecue, and everything I thought I knew shattered like glass. It was a Tuesday in late September, the kind of day where Portland's weather couldn't decide between summer and fall. I'd just finished a 12-hour shift and was looking forward to a quiet evening when my phone rang. Daniel, my younger brother by 3 years, had collapsed at his girlfriend's apartment. By the time I reached the emergency room, he was already connected to machines, his face pale and drawn. The attending physician, Dr. Richardson, explained that Daniel had experienced severe arrhythmia, and they were running tests. Everything looked like a standard cardiac event: elevated troponin levels, ECG abnormalities, the classic presentation. They started him on beta blockers and blood thinners, following every protocol perfectly. I stood there in my scrubs, watching them work, trusting the system I was part of, but Daniel didn't improve. Over the next 48 hours, he deteriorated despite aggressive treatment. His heart would stabilize briefly, then crash again. The cardiology team was baffled. They ran every standard test, consulted with specialists, tried different medication combinations. Nothing worked. I watched my brother fade, and the worst part was that everyone was doing everything right according to the book. On the third day, during one of his lucid moments, Daniel grabbed my hand and whispered that his chest felt like it was burning from the inside. Not pain, he said, but heat. That detail stuck with me, though I didn't understand its significance then. He died that evening, and the autopsy revealed something the doctors had missed: a rare inflammatory cardiovascular condition called eosinophilic myocarditis. It's so uncommon that many cardiologists never encounter it, and its symptoms mimic more common cardiac events. The inflammation was caused by an abnormal immune response, and ironically, the standard cardiac medications they'd given him had made everything worse. What did you think about what you've seen so far? Drop your thoughts in the comments below. Daniel's death broke something fundamental inside me, but it also ignited something else: an obsession with understanding what killed him. I took a leave of absence from work and spent months researching eosinophilic myocarditis. I read every published case study, connected with specialists around the country, attended conferences I couldn't afford. The condition affects roughly 1 in 100,000 people, making it extraordinarily rare. The symptoms are deceptive. They present exactly like a heart attack or severe arrhythmia, which means doctors treat it like those conditions. But eosinophilic myocarditis requires completely different interventions. Standard cardiac drugs can actually accelerate the inflammatory process, essentially poisoning the patient while everyone thinks they're helping. The treatment involves high-dose corticosteroids and sometimes immunosuppressive therapy, the exact opposite of typical cardiac care. What haunted me most was how preventable Daniel's death had been. If someone had recognized the signs early enough, he'd still be alive. When I returned to work, I was different. My colleagues noticed it. I questioned protocols more, pushed for additional testing, sometimes annoyed the attending physicians with my persistence. I couldn't help it. Every chest pain patient who came through those doors could be another Daniel. I started keeping my own reference materials, creating a mental checklist of atypical presentations. Management had conversations with me about being a team player and trusting the doctor's expertise. I understood their concern, but they didn't understand mine. Then came that Wednesday afternoon, 6 months after losing Daniel, when everything I'd learned would be put to the test. Thank you so much for staying with this story so far. I truly appreciate you being here, and I promise you, the most incredible part is still ahead. The patient was a 42-year-old man named Marcus Webb, brought in by ambulance with severe chest pain and difficulty breathing. Dr. Chen, one of our senior cardiologists, took charge immediately. Marcus was conscious but clearly terrified, his skin clammy and pale. The initial assessment showed irregular heartbeat, elevated blood pressure, and what appeared to be classic signs of acute coronary syndrome. Everything pointed to a heart attack, and Dr. Chen ordered the standard protocol: aspirin, nitroglycerin, heparin, and preparation for possible catheterization. I was assigned to monitor Marcus, while the team prepared for intervention. As I checked his vitals and tried to keep him calm, I asked him to describe exactly what he was feeling. He said his chest hurt, but more than that, it felt hot, like something was burning inside him. My hands froze on the blood pressure cuff. That was exactly what Daniel had said. I asked more questions, deviating from the standard intake. Had he recently traveled? Any unusual infections or allergies? Had he started any new medications? Marcus mentioned he'd had a bad flu 3 weeks ago and had been feeling off ever since. He'd also developed a rash on his arms that his primary doctor had dismissed as stress-related. My heart started racing. I pulled up his blood work on the computer and saw elevated white blood cell count, specifically eosinophils. It was subtle enough that in the chaos of an emergency cardiac situation, it could easily be overlooked. I grabbed Marcus's chart and went to find Dr. Chen. He was in the hallway, discussing the case with another cardiologist. I interrupted them, probably too forcefully, and said I thought we needed to consider eosinophilic myocarditis. Dr. Chen looked at me like I'd suggested the patient had been cursed by a witch. The tension in that hallway was immediate and uncomfortable. Dr. Chen, a cardiologist with 25 years of experience and a wall full of credentials, stared at me with a mixture of confusion and irritation. "Helen," he said, his voice carefully controlled, "we're dealing with a clear-cut cardiac event here. The patient's presentation is textbook acute coronary syndrome. I need you to focus on monitoring his vitals, not diagnosing." But I couldn't let it go. I explained about the burning sensation, the recent infection, the eosinophil elevation, the rash. I told him about Daniel, about the research I'd done, about how this condition disguises itself as something more common. Dr. Chen's expression shifted from irritation to concern, but not the kind I wanted. He gently suggested that I might be too emotionally invested, that perhaps I was seeing patterns that weren't there because of my personal loss. He wasn't cruel about it. Actually, his tone was kind, which somehow made it worse. The other cardiologist, Dr. Patel, asked how many cases of eosinophilic myocarditis I'd personally seen. The answer was none, except for my brother's autopsy report. They exchanged a look that communicated everything, the nurses traumatized and projecting. Meanwhile, time was ticking. Marcus's condition was worsening, and they wanted to start aggressive cardiac intervention. I felt trapped between professional hierarchy and moral certainty. If I pushed too hard, I'd be labeled as insubordinate, possibly face disciplinary action. If I said nothing and I was right, another person would die the way Daniel did. I made a decision that could have ended my career. I said I wouldn't participate in administering the cardiac medications until we ruled out eosinophilic myocarditis. The hallway went silent. Dr. Chen's face hardened. He informed me that I was being removed from the case and that he'd be speaking with my supervisor. As he walked away, I felt sick, but I also felt certain. I couldn't just walk away either. I went directly to the nursing supervisor's office, knowing I was about to either save a life or destroy my career. Margaret O'Brien had been a nurse for 30 years before moving into administration, and she was known for being fair but firm. I knocked on her open door, and she looked up from her computer with raised eyebrows. She'd clearly already received a call about me. Before she could speak, I launched into everything. I explained the clinical presentation, the similarities to my brother's case, the statistics on misdiagnosis, and why standard cardiac treatment could be fatal if I was right. Margaret listened without interrupting, her expression unreadable. When I finished, she was quiet for a long moment. Then she asked me one question. If I was wrong, could I live with having delayed potentially life-saving cardiac intervention? I told her yes, because if I was right and did nothing, I definitely couldn't live with that. She picked up her phone and called Dr. Chen. What followed was a tense conference call where Margaret, to her credit, advocated for at least investigating my concerns before proceeding with the planned treatment. Dr. Chen was resistant, arguing that we were wasting precious time on a statistical improbability. But Margaret proposed a compromise: order an endomyocardial biopsy and cardiac MRI immediately, and hold off on the more aggressive medications until we had those results. It wasn't standard protocol for what appeared to be a straightforward case, and it would delay treatment, but it would give us definitive answers. Dr. Chen reluctantly agreed, though he made it clear he thought it was unnecessary. I went back to the emergency department, where Marcus was now barely conscious. His wife had arrived, terrified and demanding to know what was happening. I held her hand and told her we were being thorough, that we wanted to make absolutely sure we understood what was wrong before treating it. The next 2 hours felt like 2 days. Marcus was taken for the cardiac MRI and biopsy, while I stayed with his wife, Sarah, in the waiting area. She told me about their 3 kids, about the life they'd built together, about how Marcus had been complaining about feeling off for weeks, but kept dismissing it as stress from work. She asked me directly if he was going to die. I wanted to give her false reassurance, but I'd learned that people in crisis deserve honesty. I told her I didn't know, but that we were doing everything possible to figure out exactly what was wrong so we could treat it correctly. She started crying, and I sat with her in that uniquely painful silence that exists in hospital waiting rooms. Meanwhile, Dr. Chen and Dr. Patel were reviewing the imaging results. I wasn't supposed to be in the room, but I positioned myself where I could see the monitors. The cardiac MRI showed inflammation of the heart muscle, but the pattern was unusual, not the typical distribution seen in heart attacks. Then the preliminary biopsy results came back faster than expected, because Dr. Chen had marked it as urgent. The pathologist's voice over the speakerphone was clear and clinical. Significant eosinophilic infiltration of the myocardium, consistent with eosinophilic myocarditis. The room went completely silent. Dr. Chen's face went through several emotions in rapid succession: surprise, concern, and something that might have been respect or might have been anger. I couldn't tell. He immediately ordered the cardiac medication stopped and started Marcus on high-dose methylprednisolone. The diagnosis was confirmed, and the treatment plan completely reversed. I felt simultaneously vindicated and terrified because we'd lost valuable time, and I didn't know if we'd caught it early enough. By the way, where are you watching this from? I'd love to know. Please write it in the comments below. Your support means everything. The next 24 hours were critical. Marcus's response to the corticosteroids would determine everything. Unlike typical cardiac interventions where you often see immediate improvement, treating eosinophilic myocarditis is more gradual. The inflammation has to decrease before heart function can recover. I volunteered to stay, past my shift, and surprisingly, I wasn't told to leave. I monitored Marcus through the night, watching every vital sign, every rhythm change. Sarah stayed too, sleeping in the chair beside his bed, jolting awake every time a monitor beeped. Around 3 a.m, Marcus opened his eyes and spoke clearly for the first time in hours. He asked for water, which sounds small, but was actually significant. It meant he was stable enough to feel normal human needs again. By morning, his heart rhythm had improved noticeably. The inflammation markers in his blood were starting to decrease. Dr. Chen came in during morning rounds, examined Marcus thoroughly, and reviewed all the overnight data. Then he did something unexpected. He asked to speak with me privately. We went into an empty consultation room, and I prepared myself for either a reprimand or an apology. What I got was something more complicated. Dr. Chen acknowledged that I'd been right, and that my persistence had likely saved Marcus's life. But he also expressed serious concerns about how I'd handled it. He said that while my clinical instincts were correct, bypassing the chain of command and refusing to follow orders created a dangerous precedent. What if I'd been wrong? What if a patient died because a nurse decided their judgment superseded the attending physician's? These weren't rhetorical questions. They were genuine ethical dilemmas that didn't have easy answers. Dr. Chen told me something I hadn't expected. He said that Marcus wasn't the only patient we'd seen with similar symptoms recently. 3 months earlier, there'd been a patient with comparable presentation who died despite aggressive cardiac intervention. At the time, they'd attributed it to the severity of the underlying condition and multiple comorbidities. But now, looking back with this new information, Dr. Chen wondered if they'd missed eosinophilic myocarditis then too. That patient's name was Thomas Brennan, a 55-year-old teacher. There'd been an autopsy, but because the death had occurred during treatment for what appeared to be a heart attack, and because eosinophilic myocarditis is so rare, they hadn't specifically tested for it. Dr. Chen said he was going to request that the tissue samples be re-examined. I felt a chill run through me. If I was right about about Marcus? And if Thomas had died from the same condition, then that death had been preventable too. We stood in that small room, discussing something that neither of us wanted to confront fully, the possibility that standard protocols, followed perfectly, had led to a preventable death. It's the nightmare scenario for any healthcare worker. Dr. Chen looked exhausted and older than I'd ever seen him. He said he was going to present Marcus's case at the next department meeting and recommend protocol changes for screening potential eosinophilic myocarditis patients. He also said he wanted me to be part of developing those protocols. Then he paused and told me something that shifted my entire understanding of the situation. He revealed that early in his career, he'd had a patient die because he'd trusted his instincts over established protocols and been wrong. That experience had shaped his entire approach to medicine. Always follow the evidence, always trust the research, never let personal judgment override systematic care. Until now, that approach had served him and his patients well, but Marcus's case had shown him that protocols, no matter how good, can't account for every possibility. Marcus Webb was discharged 2 weeks later with a completely normal cardiac function. The inflammation had resolved, and with continued immunosuppressive therapy and monitoring, his prognosis was excellent. On his last day in the hospital, he asked to speak with me. He told me that Sarah had explained what happened, how I'd fought for a different diagnosis. He thanked me, but there was something complicated in his eyes. He said he'd learned that advocating for yourself in a hospital setting is nearly impossible. Patients are scared, vulnerable, and completely dependent on trusting that the medical professionals know what they're doing. He'd had no idea that there was any disagreement about his treatment, and if he'd known, he wouldn't have had the knowledge or confidence to take sides. It made me realize how much power and responsibility healthcare workers carry. Thomas Brennan's tissue samples were re-examined, and the pathology confirmed eosinophilic myocarditis. His family was notified, and while it didn't bring him back, it did provide answers they'd been searching for. The hospital initiated a review of their cardiac protocols and developed a screening checklist for atypical presentations. My role in Marcus's case became a teaching example, though not everyone saw it positively. Some colleagues felt I'd gotten lucky, and that my actions set a dangerous precedent for nurses questioning physicians. Others felt the system needed exactly that kind of advocacy. As for me, I transferred to Seattle 6 months later, taking a position at Harborview Medical Center's cardiac unit. Portland held too many ghosts, Daniel's memory in every hallway, the constant reminder of loss and what-ifs. But I carried something with me that's more valuable than comfort, the certainty that sometimes being right means being uncomfortable, and that the cost of silence can be measured in heartbeats that stop. I still think about Daniel every single day. I wonder what kind of life he would have built, who he might have become. But I also know that his death gave Marcus Webb a chance to watch his kids grow up, and maybe that's the only redemption that matters. I've diagnosed eosinophilic myocarditis twice more since then, both times catching it early, because I knew what to look for. The condition is still incredibly rare, but awareness is growing. Every time I hear that flatline alarm, I remember that desperate moment when Dr. Chen shouted and I had to choose between obedience and instinct. I chose instinct, and someone lived because of it. But I also carry the weight of knowing that for every Marcus Webb, there might be other Thomas Brennans that we missed. The truth is, medicine isn't about being right all the time. It's about being willing to question, to learn, to adapt, and to live with the unbearable responsibility of holding someone's life in your hands and doing everything possible not to let go. That's what it means to be a cardiac nurse. That's what Daniel's death taught me. And that's a lesson written in heartbeats that I'll carry for the rest of my life. So I want to ask you something. Have you ever been in a situation where you had to trust your gut even when everyone around you said you were wrong? Have you ever had to choose between following the rules and doing what you believe was right? It's not an easy position to be in, and there's no guarantee you'll make the right choice, but sometimes that choice is the only thing standing between life and death. I'd love to hear your thoughts on this story. Would you have done what I did? Do you think nurses should be able to challenge doctors' decisions? What would you do if you were absolutely certain about something but no one believed you? Please share your experiences and opinions in the comments below. Your perspective matters, and these conversations are how we learn from each other. If this story moved you or made you think differently about what happens behind the scenes in hospitals, please consider subscribing to this channel. There are so many more stories like this, real experiences from real healthcare workers who face impossible decisions every single day. These stories need to be told, and your subscription helps make that possible. Hit that notification bell so you don't miss the next video, where another healthcare professional shares a secret that will absolutely shock you. Thank you for being here, for listening, and for caring about these stories. They're not always easy to hear, but they're important. See you in the next one.